All right. Dr. Good morning, everyone. Thank you for being with us on a Friday morning. My name is Anna Hoover. I'm with the University of Kentucky Center for Public Health Systems and Services Research. Got that order right that time. I am the former Deputy Director of the Public Health Services and Systems Research National Program Office for the Robert Wood Johnson Foundation, which just, the authorization for that program just ended a couple of months ago, and I am the co-director of our new Robert Wood Johnson Foundation National Program Office Systems for Action, and it is my pleasure on behalf of the Center to welcome you all here today. We are privileged over the next few hours to hear from a couple of our mentored research scientist awardees who are going to talk about the research they've been conducting over the last couple of years. Our first speaker today is Dr. Helen Wu. Helen is a policy and research analyst in the Institute of Population Health Improvement at the UC Davis Health System, an assistant clinical professor for the UC Davis School of Public Health. She provides project leadership and high-level policy, scientific, and statistical expertise across a range of population health efforts at IHI. Dr. Wu's work addressing chain restaurant menu nutrition has been widely cited in the general media, and she was named she earned the Article of the Year Award from Academy Health. We are very happy to have her with us today to talk about her recent research on the SNAP Ed program restructuring in the state of California. So with no further ado, Dr. Wu.
Thank you so much for that introduction. I'd like to acknowledge my funders here, the Robert Wood Johnson Foundation and the Public Health Services and System Research Program, for all of their support throughout this process, as well as acknowledging my practice mentors and research mentors for this work, Ken Kaiser and Desiree Backman. So the focus of my study is a change in how the structure of the SNAP Ed program, which is also referred to as the Nutrition Education and Obesity Prevention program within California, is managed. Let's start with a little bit of background first. I'm looking at the Supplemental Nutrition Assistance Program for Education. So this is the component of the federal food stamp nutrition assistance program that does education and obesity prevention to try and increase the likelihood that SNAP-eligible lower-income participants make healthy choices given their limited budget and also choose physically active lifestyles. So the USDA very much promotes using the current dietary guidelines and the MyPlate recommendations and getting people within those recommendations. So states vary in how they structure their SNAP Ed funds that they get from the USDA. And I'm not going to get into all of the detail of this, but essentially there are a lot of agencies involved at just one of the federal level. There are a lot of agencies involved at the state level within California, and then even more at the local level. The center of the model right now is the local health departments, and that's the big management restructuring that I'm studying. Local health departments are kind of the heart and soul of the program. They're implementing the programs within their counties. They're determining the strategic priorities. They're kind of coordinating, identifying how the program should be set up within their counties. They're doing subcontracts, and they're making agreements with some of these other funded agencies that you see on the map about kind of who does what where, so they can align those efforts best. So they really run the programs at the county level now, which is a big change from how they were organized before, where other organizations just kind of all did their own thing without much coordination within the county. So the major changes that spurred California's reorganization of the program started at the federal level. The passage of the Healthy Hunger-Free Kids Act in 2012 made a number of really important changes to the SNAP Ed program. The first was elimination of a match requirement in the funding structure. So it used to be an uncapped program that required a cost share. So organizations essentially that were able to participate in the program were those who were able to demonstrate that they were doing other kinds of nutrition education and obesity prevention activities with a certain kind of dollar matching requirement. This tended to be a lot more schools and not as many health departments because they had trouble coming up with a match share. So it has changed to be grant funding, but effectively the dollars have actually gone down quite a lot. So there's also some funding implications in that. The changes within the Healthy Hunger Free Kids program also made an expansion of the program to allow what are called PSCs, Policy Systems and Environmental Changes. So what this is that it's a provision that expands the allowable scope of activities that you can do with the funding beyond what's traditionally just been mostly nutrition education, teaching kids in classrooms about healthy eating and getting them to eat vegetables. PSCs encompass bigger interventions in the environment, working with retailers, working in workplaces, parks, just kind of thinking about how we can actually change the environmental supports to promote healthier eating and encourage those environments to happen. So, these PSC changes really open up the program to make public health involvement more important. So California, given the changes at the federal level, chose to restructure how it distributes its SNAP-Ed funding, and it's calling it the LHC model. They essentially established LHCs as the local lead agencies within each jurisdiction. What this did mean is that some local organizations got more funding, got new funding, and some organizations that had been working on the program for quite a while lost their funding. School districts and some community-based organizations lost their funding. It redistributed funds so that all counties were eligible to participate under the previous model with the match requirement. Fewer than half of the counties in California actually were able to participate, and now almost everyone is involved in that. And the state eliminated the role of certain key functions that the state does, and also some regional networks that were acting on behalf of the state. So effectively, it was a decentralization of the model to LHC. Okay. So my goal was to evaluate whether the way that California restructured its model to essentially make local health departments leads within their counties, whether that actually achieved the advantages of supposed decentralized government, and whether it maybe tried to minimize also some of the disadvantages when you localize to that level. The framework that I used to answer these questions came from a systematic literature review where I looked at literature from lots of different disciplines on transitions in public programs from a more centralized kind of management model to a decentralized model. So I looked at to see what types of features and characteristics you would be interested in when you see these changes. I identified really three main themes, which were coordination and communication, and there are kind of sub-themes within that, efficiency, and then also quality of the program. The predominant theme when you're making this kind of change from the predominant argument for decentralizing the program is that you're more allocatively efficient with a locally run program, right? So both fiscally and programmatically, you can deliver activities and interventions that are more appropriate for your local population instead of having a kind of generic program that's one size fits all. And you make sure that your funds are spent on things that really matter to the community. But there are some disadvantages as well to having a decentralized program, and I'll kind of get into those in some of the more specific findings. But the themes that are listed here are the topics that I use in my semi-structured interviews with respondents to kind of talk about and assess their take on what these characteristics look like under the current system. Going through the intro pretty fast, so I can spend some more time on the findings. So I did key informant interviews over a course of about 6 months. This happened during an interesting time in the program. The transition was a pretty long one. The federal changes happened in 2010, excuse me, and states started to really phase in some big changes in 2012 or so. When I did this interview, it was effectively the second full year of implementing the full model, even though local agencies had kind of been preparing for this for a long time, and there are still clearly some transitional and administrative changes that were being made. Use standard protocol for semi-structured interviews, anonymous interviews, audio recorded, transcribed. I did an analysis in Atlas TI. I looked to get a really good sampling of respondents from all the key stakeholder agencies that you saw in the previous organizational chart at the federal, state, and the local levels. And I worked pretty hard to get out to as many different localities as I could within California. It's a huge state. And Madera County is just very different from Los Angeles County in so many ways. So I wanted to make sure that I even kind of oversample some of the smaller counties to get a sense of what was happening there. I used an in-person format. I thought that was very important to kind of achieve some rapport with my respondents. And I continued sampling until I felt that I had achieved saturation. So new people that I was talking to didn't seem to introduce new concepts that I hadn't heard before, and that gives you some more faith that you kind of have everything covered. to the findings. So all in all, I spoke to 57 people. I held 41 interviews, so most of them were one-on-one. Sometimes due to kind of scheduling and staffing issues, we had group meetings with a few more people. I do prefer one-on-one because you get different responses when you're with somebody versus when you're with somebody and their boss and the people they work with. But I tried to get one-on-one whenever possible. I spoke to only 4 respondents from federal agencies from USDA. The USDA doesn't do very much as far as oversight and management of the program, so that really was everybody. It was like all the way up to the state administration leadership. I spoke to people in all of the state oversight agencies in California, which is probably more agencies managing the program at the state level than really needs to be done. And then I went around to 15 different local health department jurisdictions, which are usually counties, with a few exceptions, in California. Some of the people that I spoke to had responsibility for multiple counties. So that's kind of where that 15 number comes in. In addition to local health departments, as my schedule permitted, I also tried to speak to some of the other agencies that are funded by SNAP-Ed, which don't have as major of a role, but they're responsible for kind of working with LHD and coordinating with them. So some of the subcontractors and the smaller funded agencies to get their perspectives, and that was pretty interesting. California divides itself into 7 regions for SNAP-Ed. I made sure that I hit at least one local health department jurisdiction in all of these regions. And the LHDs had a wide variety of different organizational characteristics, and the respondents also did. Because there were program transitions that happened recently, there are some staff who had left their positions, and I was thankfully able to talk to people who are like recently retired, who have a lot of experience in their program. But most of the interviews that I spoke to had been working in the SNAP-Ed program in their counties for a very, very long time, like a lot of 10, 20-year veterans, so they had a long understanding of the history of the program and could really compare the changes recently to previous versions of it. The organizations that I thought also included those, who were new to the program, so they provided a very kind of fresh perspective as newbies. So the premise of this study is that I was looking at a new decentralized governance structure for SNAP-Ed within California. But that said, it is not a purely local program in terms of, thinking of one that's driven by local finances or local taxation and completely governed. It's a federally funded program that has strong state oversight and strong state rules that they are calling one that is much more local now because it is pushed to the counties to be led up and sort of directed and dictated by what the local health department thinks is important within the county. But that said, the federal agency sets some very tight rules for what you can and you cannot do with the money. And the California agencies, the state health department in particular, which is the biggest agency, also has a role. They approve the curriculum and the materials that can be used. So local health departments have to choose from something that's already been approved by the state to use. And there's a very strong role of state approval in what you do. So let's just kind of put it that way. So local health departments, they have some flexibility and they have some leeway to figure out what works best within their populations, but they have to work within some pretty strong state and federal oversight rules, even though it's a more local model now than it has been in the past. Okay, so let's get to one of the first key findings within the topic of coordination and communication within local jurisdictions. So what I did in my analytical approach is I took these key concepts that I asked people about during the semi-structured interviews, and then I kind of looked to see what did the literature say. Is this supposed to be an advantage or a disadvantage under decentralized management, and what evidence do I find that's either positive or negative, kind of supporting these conclusions. So coordination and communication within local jurisdictions, it just kind of makes sense that you would think it's better under a local run model, right? You have local agencies who know each other, who have established working relationships, maybe even personal relationships over time in some of the rural counties. And so you would expect to have some pretty much better coordination and communication when you switch to an LHD model from a state-led model. And I saw some pretty good evidence that this did happen. I think that people were saying, well, as a local health department, we're in a really great position to coordinate our county partners. We know these other organizations, we know the people, we know the strengths, and we can pull everybody together in the best way. But that said, with these new requirements that actually came down from the state was saying, okay, LHTs, you guys have to coordinate everybody in your region, decide who's going to do what, and come out with these work plans. Well, that creates some tensions, right? Right? When you have, in some cases, you had a local health department staffer taking on a leadership role as kind of the coordinator within the county who's kind of new to the program and stepping over people who have been working on it for 20 years who knew a lot more than that. So there are political tensions, organizational tensions, interpersonal tensions, and just the need to achieve consensus on a local level is not very easy. So overall, I think that the new model did achieve this advantage of decentralized management, but not without some friction between organizations. Coordination and communication across regions. So you would actually expect this to be a disadvantage under the LHC model. So the state has an interest in making sure that regions all talk to each other, that there aren't any regions that have huge inequities in their performance or their skills and ability. But when you have a decentralized model, people are focused on the needs of their constituents and their own communities. So they're not taking the time to share information with other regions, and best practices can be pretty time consuming and pretty burdensome given everything else that you have to do. So, I found some evidence of people saying that, oh, I call so-and-so in this county when I have a question, and they've been really helpful. The state definitely has some support mechanisms to promote information sharing about challenges and best practices to help new organizations get through it, but people were not very enthusiastic about the quality of the state support. They said the state support tended to focus a lot on showcasing who did really well and not as much on letting people kind of voice their challenges that they were having. So it was very difficult, particularly for new organizations coming into this funding, to find ways to really ask the dumb questions, which is really what they needed to do some of the time. So I think this disadvantage, unfortunately, was realized under the model. Coordination and communication between local agencies and the state. So you might expect this to be problematic under a decentralized model because when localities have the flexibility to perhaps do what they want, then you lose coordination towards a common state goal, a common state vision. And I did hear a lot of comments from respondents saying that they felt that they didn't know what the vision was at the state level. And the state definitely struggled with knowing how do we evaluate the impact of this program when it's actually a collection of lots of different things that are happening in different counties, and we're supposed to report back on a state and say this is what we're doing in California, even though there are all sorts of different interventions. So there were a lot of comments just kind of saying counties were doing their own things, and this is problematic when you look at it collectively at the state level. Now, the benefit of this, of course, is that when you have a little bit less state guidance, and that gives local agencies a little more needs and wants out of the program, and some that are really new to the program. So I think that this disadvantage was realized under the new model. Okay, administrative efficiency. The literature is pretty mixed on whether you can run a program in a way that's more administratively efficient when it's local versus state. There's some writing that suggests that state bureaucracies they're extremely slow, they're hard to get through, so maybe it's better in local bureaucracies, but then you have things like boards of supervisors at the local level that you have to go through, and sometimes even one of the very small rural counties that I went to, somebody was like, you think it's a small county, you can move things quickly, but I have to get everything approved by the board of supervisors. Whereas in LA County, there are protocols in place to move things along a little more quickly, so it's not necessarily true. So, so I wasn't really sure where administrative efficiency was going to go, and obviously I'm relying upon people's subjective views. I didn't kind of have hard data on administrative efficiency for this, and I found some mixed results. I found some good evidence that because local health departments are managing a lot more of the administrative process, for the SNAP-Ed grants, they have more control over things like subcontractors. So I had somebody from a very experienced agency kind of telling me, oh, this subcontractor had been working for years under the state, and they're just doing all this stuff that I don't think it's even effective. Like, why are they trying to use persimmons as an example of healthy eating. Do they really think that's going to make a difference when they're seasonal and it's not something that you pick up and eat every day? But I thought it was kind of cute, and it's just like, this doesn't even make sense. They're using all this curriculum, and I can have much tighter quality control on what I think works, because I'm here in the district and I'm working with a subcontractor now instead of having a state agency, which was pretty arm's length. So there's a positive side of local health departments being responsible for the administration of it. But that said, it is less efficient administratively, pushing a lot of these tasks to the local health department, because it doesn't eliminate the federal and state approval requirements. So they're still there. They just added the layer of local bureaucracy that's required. And this created some pretty tricky situations. So if the state is in a situation where they're saying, okay, well, this is the timing of the budget, and this is what we know about your hiring, and then we're going to release that information to you at this time, and then it doesn't line up with when the county hiring process needs to happen, or you have like a 1 month window, it doesn't work out very well often administratively. So, there are mixed results, both pros and cons, I think, to the local administrative aspect of this program. Okay, so fiscal efficiency is one of the stronger arguments around using a decentralized model for public management. One would think that within local administration, spending can be much more transparent. It's closer to the community. You have greater responsibility and kind of stewardship for showing results to groups like your boards of supervisors than at the state, where it's much more opaque what's really happening with the spending there. And I think that this is actually true. I heard a lot of really interesting comments from people who are saying, this LHC model that we have and the funding structure forces us to be very strategic. We sat down, we mapped out which populations we wanted to work with, and we want to make sure that we show good results because we're controlling the money now, and we're determining which pockets of the community it's going to. I had somebody in one organization saying that, under the previous program, there was a school district with only 5% of their kids were low-income eligible, and they had a huge chunk of funding because they were able to come up with a match share. But under the new model, she's like, I'm controlling the funding, and I want to give it to this other school district that has 65% of their kids are low income. That's where I want the work to happen. So that's where I'm going to direct it. And obviously somebody's going to be unhappy when the funds move around, but she's like, that's where it needs to go. So you see those good examples of better use of local control of the finances to direct it to the communities that are in need. But that said, I could not get out of an interview without people complaining about how difficult administratively it is to do the financial management of this program. And it's just a huge topic, and it's very difficult. It's complex. The rules are tough. The documentation requirements are burdensome. And so fiscal management, with the privilege of that control, comes a great deal of responsibility for the fiscal management. And so it's very difficult for people. And there's also a sense from some respondents that they don't have complete control because they still do need to have things approved by the state. So there's some people who kind of felt that local control was perhaps a little bit of an illusion because they would want to do some sort of approach, and then their program officer at the state would say, no, maybe you should try something else. I'm not a big fan of that. So it's kind of this tension between the state wanting to do quality control and oversight with allowing greater local flexibility. Okay, programmatic efficiency, I think, is really the most compelling argument probably for decentralized public management and programs. This idea that allocatedly you'll be much more efficient and you will direct all of your activities towards the communities that need them the most. So it's an anticipated advantage, obviously. And I saw, kind of mixed results on this. I think to a slight extent, communities were able to do this better. There's some people who are saying, it is a more local program than it has been in the past, but there are differences of opinion on that in terms of the amount of state-level control that they saw. I think the first quote up here came from somebody who's not experienced in the program. So, he said, well, I see a lot of state direction, and that's great because I want that guidance, but they're leaving it up to me to determine what I really want to do in my communities, and that's great, and I have that flexibility. But I think, other people, I think, particularly those who are more experienced in the program and they want to operate with a greater level of autonomy, felt that they were really restricted The activities that you can do, by and large, are chosen from a menu of pre-approved state strategies. So even things like handouts, educational handouts, materials, you have to use the state one. You can't change the color. You can't change the font. This is problematic because they brought in the Department of Aging and gave grants to do nutrition education in seniors. So everything is there in a 12-point font, and they're not allowed to change them to a 14 or 16-point font because it's not evidence-based to use that font or the different color. Yes, seriously. So there are approval processes for trying to get that changed, but they tend to be very slow. So this is the challenge in trying to really customize materials to your population that people face. Okay, so what about the quality of the program? A lot of the literature kind of talks about whether the quantity of output may differ in a localized model. I think that's not quite as relevant because the funding changed a lot, funding dropped a lot, so we're not really going to talk about changes in the quantity of services because they necessarily have to go down to some extent. But with a local management model, you expect greater community engagement and then so maybe some more innovation. But that said, SNAP-Ed is not a program that encourages innovation. It's a program that encourages very strong evidence-based approaches that have been tested and proven to be effective over and over again through published studies. So that's the approach. That's the kind of the culture within SNAP-Ed. There are ways that localities, if they have something that's a little bit different that they want to do, they can go to the state and try and get approval for that. But it's a battle getting that approval, and it can take a long time, and by the time you get the approval, you might lose momentum on what you're doing in the first place, and your partners have lost interest. So being innovative is pretty tough under the SNAP-Ed program. I had to really reach to find a positive comment related to innovation, and I think the best that I could really find is people trying to be maybe not innovative, but more creative in how to make their dollars work. So when they wanted to do something out, kind of a policy systems and environmental change that might involve a capital improvement project, they can't use the SNAP-Ed funds for that capital piece. So they would think about how they could bring in other partners to match up funds to get the project completed. So they have to really work to kind of line up the different rules and restrictions. And people were as creative, I think, as they could be, given the demands of their daily schedules and everything else they have to do. And being able to kind of achieve community impact within the rules of the SNAP-Ed program. So even though this should be an advantage under the LHD model, I can't say that it was achieved. So finally, quality is a concern in a decentralized model if you are worried about things like geographic inequities, so smaller and rural counties perhaps maybe not having the technical skills to carry out certain programs to the extent that they could under a model with very strong state support for those types of skills. And I think actually I'm fairly optimistic about this one. I saw that a lot of the smaller and rural counties using more unique organizational structures to get around it. So they were allowed to use subvention contracts. There are a few small rural counties that partnered with a community-based organization to do the work for them, basically under the premise of the local health department, and that was another organization that they felt was better equipped to do it and more nimble, so it kind of got around some of the local challenges. There are also some rural areas that use a cluster model, so there was one kind of a larger rural county that had a university or some other resources that they could do this program, and they worked on behalf of the multiple surrounding counties and maybe had staff that would go out once a week or so to those other counties and do the work. So the rural counties are finding ways to be creative about it because it's not their first time dealing with this type of a challenge. That said, there were certainly a few comments I got here and there, people saying, yeah, you know, some of these health departments are just not positioned for success. California is maybe thought of as a pretty liberal state, but there's a lot of very rural and conservative California as well. And so I was even hearing comments like, well, there's people working in these health departments that don't even believe in promoting healthy living. They think it's a government intrusion on your personal rights, so they don't even believe the premise of the program that you're talking about. And certainly they don't have support from leadership to even work on these programs. So, you know, I think that's maybe more the exception than the rule, but it certainly is not something that we can ignore, that some local health departments just They don't have a good infrastructure for doing things like subcontract administration under a very complex program such as this, and maybe they're working on other core public health services that don't include work on obesity prevention, but outside the scope of what they've been doing. So I think that for this feature, the disadvantage was realized in some local health departments, but others did find ways to overcome it. Okay, so overall, what I think out of this assessment from California's experience is that I didn't find compelling evidence that would lead me to recommend to other states you should go with this universal model to have local health departments deliver your services. The success of implementation depends on the capabilities of the organization, and the LHC may or may not be the best organization in the county to do that, depending on that particular group. So with the transition that California made, I saw some of the advantages of decentralized management were realized, but some of the disadvantages were also realized. And one of the biggest sticking point is just the federal and state rules that really limit the ability to which this can be a local program. And it's not to say that those rules and restrictions don't have value. They are intended to provide greater quality control. They're intended to provide some structure because you can talk to some local health departments who are saying, oh, there's too much coming down from the feds and the states, and then you go to some other ones, it's like, we want the state to tell us more what to do. We don't know, because we're just going to them to ask them to approve our plans. We don't know what they want, so just tell us. So there's just kind of this constant, I think, philosophical disagreement from people about how much direction they want from the state. And there were even some pretty experienced respondents from health departments who said actually better state structure would be better, because I don't really know what the state is doing at the California level on this program. So, pros and cons to the decentralized model, I think. And just to wrap up with implications for policy and practice. So the federal changes that were made to the SNAP-Ed program, I think, because they eliminate the match funding requirement and replace it with the grant structure, you don't have to document cost share anymore, and you're allowed to do policies and systems and environmental changes. It opens up the program for a stronger public health role than public health has played in the past. The use of local health departments in such a strong central leadership role in California is actually unique. Most states don't work with health agencies very much. They work with cooperative extension offices, universities. They do much more of a traditional educational model, and they don't do very much kind of on this policy changes that come from different sources in the past. So states can rethink how they want to structure their SNAP-Ed programs to take advantage of the fact that they can do these PFCs, take advantage that you don't have to come up with a match share, so who was left out of it before. But that said, my lesson for other states that are thinking about doing this is that make sure you consider the very high cost of restructuring and shifting the funding from one organization to another. It really needs to be worth it in the long run. SNAP-Ed program is very complex. It takes a long time to learn, so the transition costs are tremendously high. Work with organizations that may not all fall under the same category, but whichever local organizations you think can deliver those programs best. Maybe think about more competitive structures for funding in your state. The California model is not a competitive structure, so any local health department says, I want the grant to do it, gets it. And that results in maybe some places who don't really implement the work with the level of fidelity and the level of kind of passion that others do when it's non-competitive model. And finally, for other states, you might want to try small-scale pilot approaches before rolling out a universal model that restructures things. That was definitely a clear criticism that I heard from some of the respondents, that it was basically a pilot case with a $100 million a year program that just rehauled things and changed everything all at once. And maybe there are reasons from the state administration level that you might want to do that so you have certain types of support, but they didn't pilot it very well, and so other states might want to try that before they rehaul the system entirely. Okay, so let's open up for questions and discussion.
And get us started. And while you're thinking of your questions, and we might ask Helen to repeat questions, not out here. We talked a little earlier before this session about the differences in the way the program is evaluated, the effectiveness of the program is evaluated by those who are involved in it and by outside interests. I wondered if you might share a little more about that with
Sure. So the question is about how this program is evaluated by various groups. The literature that I've seen evaluating the SNAP-Ed program to date, it does not look at the impact of the management or organization structure. It kind of has your program evaluation, kind of your traditional approach where you look at the impact on recipients and communities. Are people eating more fruits and vegetables? That's kind of one of the main evaluation measures that they've used in the past. So there hasn't been a PHSSR type lens put onto this program. And B, the evaluation that I've seen is pretty much all done by somebody in the program. There is tremendous political pressure starting up at the federal level to look good, to look like you're doing everything well. So when you take a program the scale of California's and you make a big change, let's just say there's a strong incentive to make sure that you cast that in a positive lens. So really the benefit of being able to do this work under the Robert Wood Johnson Foundation funding is that I could come in and take really that critical friend eye and just look at the program objectively without needing to necessarily make it look good, and just kind of see what all of the different challenges are, because what has been published to date tends to focus very much on successes and not so much on the challenges and the opportunities for improvement. Given that states have such unique structures, funding and kind of organizational structures for SNAP-Ed, we can use some more information out there about what's not working very well and what other states are doing.
So I'm the coalition lead on a CDC-funded project to implement healthy behaviors through extension services. First-time CDC is partnered with extension. That also involves partnerships with local health departments that hadn't always existed in the past.
Yeah.
And here in Kentucky, of course, SNAP-Ed is all based in the extension service.
Yeah.
And you alluded in your conclusion that that's still the model for SNAP-Ed delivery in most of the states.
Mm-hmm.
And so I'm wondering if you could talk a little bit about specifically the interagency relationship between extension service, which I know is very strong in California,
Yeah.
the transition over to the local health department and what those kinds of collaboration or failures to collaborate might have looked like.
So the question is about the partnerships and collaborations between Department of Extension, which has traditionally been very strong in this program, and local health departments, which are in some cases newer to this program. There is one very memorable site visit to a rural county where I had a very strong and experienced cooperative extension specialist who had been working with this program for a long time, who was leader within the county. And honestly, she had a lot of complaints about the health department's management of the program. They were a group that was new to it. They didn't understand the program well. They somehow, though, were getting all the funding, and they were being told that they had the leadership role in kind of convening their partnership meetings. But the one from the cooperative extension, who was much more experienced, she's like, I'm the one who's actually doing all the work. I'm just not getting funded for it. I'm not getting the credit for it. So, that's happening when you have veterans who, even if they're not getting funded that much because of the passion and their experience in the work, they end up being mentors to kind of the newbies in the program. So there are definitely tensions between the cooperative extension offices and the local health departments. Cooperative extension in California doesn't cover all the counties, so so that's one difference. I think they might have fewer than a dozen regions or so, and they cover the bigger counties, but some of the smaller rural counties don't have cooperative extensions, even though some of them do. So that's part of a lot of the tensions that I saw.
So I'm interested in the program design aspect. So my question would be, do you have access or previous people who designed the university model? And because you said it was sort of not ideally pilot tested, which is launched,
Yeah.
at large scale. That would be my first question. The second question would be, talk about the difficulty that a lot of those have in happening or the inherent constraints because of complex rules involved in state. But more of the question of presentation, although it was a centralized model, but
Okay, so the first question is whether I talked to people who are responsible for making this decision to restructure the program at the state level. I spoke to the key leadership at all of the state health agencies. Not all of them are counted in my sample size because some of them were informal conversations. I think they didn't want to participate in a formal capacity, but I did get some input from them, and I'm sort of told that the key people who made the decision are gone from the agency.
Was it from the office of the governor?
The California Department of Public Health is one of the biggest players, and senior leadership there does change a lot. But I was told the key leadership responsible for making that decision was gone. So there's political stuff going on with California. Essentially, I think the decision to transition to the local health department model, there are a lot of justifications on why it makes sense from a public health perspective. But Governor Brown also has a promise to counties to push more to the counties and push a lot away from the state. So there's a strong political environment that's really just pushing funding and governance to the counties and away from the state. So I think a lot of it was behind that. There's a lot of political context around it. And so the second question that you had was around fiscal decentralization. So, and kind of whether it's really decentralized at the local level. I think it is and it isn't. There are always going to be some state and federal level control on this program. It's sort of, it's reviewed and audited in a way that's more in line with federal assistance programs like food stamps programs, which really audit for kind of compliance and abuse. And so it's not really traditionally audited or reviewed in the way that public health programs are reviewed. So they're accustomed to kind of doing a lot of counts and just making sure the money's not being spent on things it's not supposed to be spent on, as opposed to doing kind of like program review. So, you know, for that reason, fiscal decentralization, it's much more decentralized fiscally now than it was in the past. Under the match-based funding model, basically the organizations at the local level that got the match, they did the documentation to demonstrate the match, and then the money kind of went up to the state, and they're pretty much at the mercy of the state to kind of get back part of that match there. So now local health departments do, I think they have a lot more discretion in determining where finances go. They can determine whether certain subcontractors are not qualified, you know, so they can oversee those subcontractors. There's one county that I talked to where the LHD kind of made a strategic decision that was clearly not fully accepted by the players in the county yet, but they decided that to maximize their funds, instead of trying to spread them out throughout the entire county, they were going to pick 6 communities that they were going to work in. And they wanted to achieve strong intervention intensity in all of those communities and really kind of hit them with lots of different interventions. And, you know, some of the players were not very happy with that because it meant pulling out services from other places where they had been working for a while. But the LHD really felt that, you know, that's how they wanted to direct the funds and the activities, because they felt that they could see impact in the communities that way. And the previous model, they've been doing kind of their own thing for a long time and didn't have very much to show for it.
They still have to have certain lines of state.
Well, the state determines, first of all, how much the counties get. Right. So, and that's based on a formula that's linked to the number of SNAP eligible people that are at the county. So the state has discretion over the total budget, and the state signs off and approves expenditures. So you tend to work within things that you know are going to be approved. It can be a big financial liability to you if you try and do something that's a little bit off what you think might get approved for an expense, and then later you end up finding out you have to cover it yourself because it doesn't get covered. But it's pretty challenging when you're trying to do things that involve policy and environmental changes, building community gardens, and they say, oh, but you can't use it to buy supplies for your community garden because the program, you know, it doesn't buy supplies. It buys food tasting samples if you're doing nutrition education. It doesn't buy dirt and seeds, you know. So it is a little crazy, the documentation with the program.
Do you think it would have, based on what you found for your study, would it have been better if it was a hybrid approach where in each decided whether the health department or some other agency, but that it would, you'd have the advantage of someone in every county providing service, but not necessarily just the health.
The problem is that the model was not based on decision that that is the most appropriate for every county. They are capable of figuring things out, but in other cases, there's not a strong amount of confidence in the health agency's leadership. They said that there wasn't really any leadership and they weren't doing much. And it was organizations that have been working on this for a long time that were doing everything. So yeah, so that's the challenge with coming out with a model that says everybody's going to do it this way. It doesn't recognize the variations and the strengths between counties. So I think that there's a little bit of a mixed approach. In the small rural counties, some of them that were using, say, subvention contracts, and they are working with a local community-based organization to actually implement that activity, that was kind of an instance where the local health department said, we don't want to take this on, we're too slow, we can't process it administratively, you guys know how to work with the community, so we're going to have you guys work on our behalf. So that did happen in some cases, yeah. But there are probably some other instances where the health department should have said no to the money or push it to another organization, and they chose to take the money for themselves.
In public health services, always thinking about 3 Ds, efficiency, equity, effectiveness.
Yeah.
I think in your talk, we hear a lot of things that really point to efficiency and effectiveness.
Mm-hmm.
That is very important to look at. So, with really good research, especially really good qualitative research, field as many questions, we create as many questions as we answer. So I'm wondering, thinking about this work through an equity lens, and thinking about what you were saying about the distribution of funds and the formulas they use, and what you heard on the ground from the health departments, what are the implications? What are the big equity questions that bubble up for you?
Mm-hmm. Okay, so the question is about what the major equity questions are that bubble up from this research. So a couple ways to look at equity. One is the equitable distribution across counties, and then the second layer is kind of looking deep within counties at specific target populations and whether there are disparities that are kind of happening there. I think within across counties, the small and rural counties don't get very much funding. Some of them are getting, the smallest ones are getting $200,000 of funding, and given the cost of administrative structure of what it takes to run this program, it's not even full FTEs of people who are running it. So actually a few counties, there are 61 local health departments in California, and 3 of them have, at least some of them most recently, are not been convinced that it's worth their trouble to participate in the grant. So they just said, thanks, no thanks, we don't want the money, it's too much work. So the current model it's more equitable in the sense that there are a lot more counties that participate in the program now. Every single county that wants some dollars, wants some funding to work on the program can do it now. And under the previous match-based model, a lot of the counties couldn't come up with a match, so they didn't participate. So there's nothing there. So there is a more equitable distribution across the counties. Within target populations, specific communities and populations, I don't know that this change really affects that, even though it certainly is a consideration within communities. I would say that one challenge is that since all the localities have to work within state-approved materials, if you have a particular group, like among population, they don't have state-approved materials for that. They have a Hispanic set, and then they have like the generic English set, and they have one set of materials that's geared towards kind of African Americans and a faith-based approach. But there are a lot more populations than that in California, and so localities who identified pockets of need within particular communities and wanted to do work in them, they definitely struggled. I think that it's the same struggle as they had under the previous model, actually, as they do now. So there will continue to be, I think, some of those disparities. And there are ways, maybe through regional centers of excellence that USDA is starting to fund, or I would say that the state within California has actually done a lot more development of materials than any other states because of the level of funding that it's had. Other states actually haven't even been authorized to develop curricula that are approved until, I think, a little bit more recently. So it's a problem. I would say it's a problem for any of those communities that fall outside of the big group.
I just have one other
Yeah.
quick one. What was your most unexpected finding? What was your big surprise?
Surprise. I don't know if I had any huge surprises with this. I did another evaluation for the state, actually working on behalf of the state agency that was funding this at the same time. So I had already gotten feedback. We did telephone interviews with every single health department in the state that was funded by this, whereas this, since I did in-person site visits, I had to kind of limit and sample on it, just went around to a selection. So I already was able to hear from every single health department about some of their challenges that they've been having. So I don't know that I got any huge surprises in there, but I think probably two things that stood out to me most in a few counties were when I talked to multiple people who are supposedly in partnerships and got conflicting stories about how well they really work together. So, and I did that kind of deliberately because everyone you talk to is going to come in with a bias, right? So even if you're a newbie to the program, like you want to look good. You're not going to say I'm struggling. You're not going to say, they shouldn't have given the money to me. They're going to give me a pretty optimistic answer. So then you go around, you talk to other people who have to work with them, and you get other perspectives. And so that was kind of my method of mitigating bias. And those were some of the sometimes surprising findings, hearing what people say about each other in the same county.
Okay, thank you.
Please, and thank you, Dr. Wood. As a reminder, at 12:30, tomorrow, I always want to say tamer, and tomorrow. That's not, that would be wrong. I know. I blame the British. But tomorrow we'll be speaking at 12:30 about some research she's doing about positive deviance in rural child health services. We hope you'll join us for that. After hearing all about great education on nutrition and obesity prevention, we offer you pizza. It's not quite here yet. If you'll give it just a couple of minutes, then there should be pizza in the hallway. And we hope to see you back here at 12:30. Thank you again for being here this morning, and thank you again, Dr. Wu.